Hi, I'm Dr. Frank Speidel, and welcome to The Doctor Is In. I have been board certified in emergency medicine for 40 years by the American Board of Emergency Medicine and practiced emergency medicine over 4 decades. I'm also a former hospital administrator, having been a chief quality officer, a chief compliance officer, a chief privacy officer, a chief medical officer, and a chief executive officer. As such, I have experienced how our health system works, and it works well. But I have also experienced how it fails, and it can and does fail. In The Doctor's In, I want to examine and explore healthcare in the U.S., which, as Charles Dickens phrased, is the best of times and the worst of times. And speaking of the times, perhaps a word about COVID-19 would be in order. Have you ever heard the expression, "It's just a virus"? Wow, the devil's in the detail there. For months, there has been a tsunami of reporting on the most recent human pathogenic novel virus, identified and named SARS-CoV-2, causing a human disease labeled COVID-19. Before the details of COVID-19, perhaps some words about conventionally accepted basics are in order. What's a virus? For me, I understand a virus as a complex packet of organic, carbon-based molecules, RNA or DNA, that serve as a set of instructions for cells, code, as it were, to do things. The packaging of these instructions is designed to attach to a cell, invade the cell, use the cell to reproduce and assemble more instructions, DNA or RNA, and packaging as well, and then leave the cell, in the process usually destroying the cell or making it incompetent. In living things, the destruction and compromise of cell function results in disease. Humans are and have been susceptible to viral disease. Human viral diseases are legion, ranging from the inconvenient fifth disease due to a parvovirus virus, parvovirus B19, for most, and for many lethal, such as Ebola, Florida virus, the Ebola virus, to terminal for some, such as rabies, the rabies virus. This slide shows you're going to see just some of the many viruses that are out there that we're subject to. You'll see Spanish flu down to avian flu. Now, viruses may be virus specific or may be able to infect multiple species. When sharing a host such as the bat coronavirus does, it may share the virus with another virus also infecting the host. It may then trade its messages, the RNA and DNA, so that a new virus is created. We call that a novel virus, such as the novel SARS-CoV-2 virus, which causes a respiratory disease. COVID-19. This began to emerge from Wuhan, China. Some of the initial case fatality rates reported, Hubei province reported 15%. This demands attention. However, with time and increased surveillance, the WHO published a global case fatality rate of 3.4%. This statistic, the CFR, case fatality rate, is challenging as it is multifactorial. Aren't all things in the real world multifactorial? And as contemporary with the Chinese data, South Korea published data showing a CFR of 0.4%. The CFR is fraught with the peril in both calculation, use, and interpretation. Consider the CFR for China over time has remarkably decreased, as this next slide shows you. If the disease can present with minimal to no symptoms, knowing the number infected is the beginning of the challenges. Communities, culture, and healthcare systems are not the same. Where care is provided affects how the outcome of the care. In 2003 SARS epidemic, the World Health Organization reported a CFR of a frightening 9.6%. While simultaneously, the CDC reported the CFR in the United States as being less than 0.1%. In fact, there were no deaths in the United States. Now, as recently, the New England Journal, Dr. Fauci opined, the case fatality rate may be considerably less than 1%. This suggests that the overall clinical consequences of COVID-19 may ultimately be more akin to those of severe seasonal influenza, which has a case fatality rate of approximately 0.1%, or a pandemic influenza similar to those in 1957 and 68, rather than the disease similar to SARS, SARS, or MERS, which have had case fatality rates of 9 to 10% and 36% respectively. Going locally, Dr. Paul Offit, who holds the Maurice R. Hillman Chair of Vaccinology at the University of Pennsylvania, holds a similar opinion. That is, the CFR is approaching seasonal influenza, and says he cannot imagine COVID-19 will cause 1/10 of the damage of seasonal influenza. Another metric that is useful but also problematic is the R0. These values are a crude approximation of a disease's ability to spread, likened to how many people an infected person will transmit the disease to. In this slide you're seeing right now, you can see the case fatality rates in R0s for relative diseases. In particular, note the 75% for Ebola and the high infection rate of 12 to 18, the high transmissibility R0 of 12 to 18. The infectivity is profoundly less than measles, and that's an important thing to carry away. It's in the ballpark of influenza. Now for a perspective on COVID-19, the illness, and our response to it. You're going to see another slide now, and that's about this. Seasonal influenza, according to CDC, kills about 36,000 Americans a year. During the influenza season, which is seasonally limited, that comes out to about 300 patients a day die from seasonal influenza. What about immunization? We don't have immunization right now for the COVID-19, but we have for influenza. Well, our influenza rate, as this slide will show you, is around 47%. Dr. Offit, who I greatly respect, has been quoted as saying, there has been a wild overreaction to the disease, in part because it's new. We're more the victim of fear than the victim of a virus. Now, testing for CoV-2 has been a faceplant right here in the United States, but not in South Korea. Given the triad of fever, cough, and shortness of breath, what would one do differently, whether the origin was H1N1 or H3N2 or SARS-CoV-2? Finally, is the response fired by a ratings craving in the media, all this publicity, or is this novel virus really that harmful and different from our seasonal influenza? For myself, I think we live in a sea of pathogens and a few people with violent dispositions and some seriously lousy drivers. And I sense that the world is neither fair nor linear. Stuff happens. Yet the best course of action is to live fully, aware, thinking, and with kindness. And yes, a certain acceptance for the risk of living. For as Bilbo Baggins advised, it's a dangerous business, Frodo, going out of your door. Joining me today is our guest, Dr. George Avetian, the Senior Medical Advisor for Delaware County. Dr. Avetian, thank you so much for joining us here on The Doctor Is In.
Well, thank you for having me.
You're answering questions about this all the time, and I greatly respect it. It's not easy to stand up there and try to make sense of all this science in a way that everybody can understand. Things are changing, as we talked about earlier. Nothing's new here. What should the community be doing? How should we respond to COVID-19?
Obviously, we need to respond in a rational, non-panic way, and realizing that with COVID-19, we don't have a preventative vaccine or a identified treatment antiviral. What we need to focus on is what we do with influenza. And with prevention of influenza, we focus on hygiene, thorough hand washing, instructing individuals when they're ill to stay home, not to expose others, not to go to work. If the children are sick, don't send them to school, don't send them to the daycare. And of course, if you must sneeze, in a handkerchief or in a tissue, dispose of it properly, wash your hands afterwards. Common sense things.
Some have said that the public is receiving mixed messages. That's probably me. I think we're sending a lot of mixed messages, whether intentional or not. Is there any confused messaging that you think people should be clarified about?
I think there are mixed messages being promoted out there, and unfortunately a lot of it comes from social media. The messaging that we want to get across is based on fact, based on what we know. It is not based on panic or fear or unrational ideas. What we want to do is inform the people, inform the public. This is a virus. We have had this virus on the map. The World Health Organization identified it back in December of 2019. And it was identified as a result of cases of pneumonia in China that were of unknown etiology. It didn't take a month. On January the 30th of 2020, the World Health Organization declared this a public health emergency of international concern. And if we move forward, February 11 of this year, it got its official name, COVID-19. And just recently, on March the 11th, it was declared a pandemic. So we are learning about this virus, and based on fact, we are then providing information to the public as to how to deal with it.
Do you think the media is being an asset or a liability during this epidemic?
Both.
We're agreed.
Okay. I think, unfortunately, they fuel a lot of the anxiety and a lot of the panic. And it's best that rational minds prevail. I think that they are very informative. They do communicate the concern that healthcare professionals have. And, we are working very hard. We're working collaboratively with all of our partners. Twice a week, the World Health Organization has a web-based consultation with all the thought leaders throughout the world. So the important thing is the press needs to push forward proper, rational, scientific information and instructions based on what the medical community thinks needs to be done. I think to fuel the fear and the anxiety is just a horrible side effect of what's going on.
We sort of have been talking about that before in the green room, about the concept that in some ways this is, it's something that people want to know about, and the more exciting the headline is, the more viewers we have. That the old expression, if it bleeds, it leads. Mm-hmm. It's an attention grabber, bad news, things falling apart, catastrophes. Do you think that as opposed to the conveying of information accurately is driving some of the media?
Well, the media is out there to report news. And, currently, for example, when was the last time that you recall basketball matches being canceled, March Madness being canceled, the hockey season being canceled, baseball under the threat of not starting, schools being closed? In my lifetime, that really has not occurred.
I think the last time it happened was when that meteor hit the Earth and wiped out the dinosaurs. It just doesn't happen. I mean, this is massive.
So it is newsworthy. It is newsworthy. However, again, panic should not rule the process. We need to be very focused on what is happening and let the scientific community take the lead. Let's go with proven ways of mitigating the COVID-19 spread, and hope for a good outcome in the end. We don't have a crystal ball where we can see what's going to happen in one day, 1 week, 1 month, 1 year. Time will tell.
We can only speculate about what it's going to look like, and the challenge for folks like you who interface with the superstructure of government that's trying to give direction and make comments is huge, and I greatly respect what you're doing. Technical question. What's the difference between isolate and quarantine? I see those terms used interchangeably.
Isolation separates a sick individual, a person who has illness, from the rest of the community, the healthy community. That's isolation. Typically, you'll see that in the hospital if you go into the intensive care unit, and you'll see a sign, and that individual is already ill and is being separated from the community. Quarantine is typically an individual who has been exposed but who has not yet manifest illness. And in this scenario, when we're talking about COVID-19, we know that there's a 2-day to 14-day window where that patient can develop symptoms. So what we do is we then quarantine. We ask them not to, it's basically social distancing, not to interact with the rest of the community until they get past that 14-day window, and we know that they're of no risk to harbor disease, carry disease, and transmit it.
So isolation refers to an individual who has been diagnosed with COVID-19.
Yes.
And quarantine may refer to a group or a geographic location where we have a concern that they have been exposed to a carrier of the SARS-2. Could you share the differences between COVID-19 and prior infectious disease outbreaks? What's the thing that strikes you about COVID-19 as opposed to, the things we've seen before, swine flu?
Yeah. Well, let's talk a little bit about, that's a little history lesson, and we kind of went over this in the other room. Spanish flu. It was about almost 100 years ago. Okay, 1918, 1919. There was no preventative vaccine, and there was really no treatment. There were lessons that we learned. And one of the lessons was people who tended to congregate in groups were more likely to have and come down with the disease. And I was taught a little lesson, which I shared with you from a history teacher. And that was in Philadelphia, when we had Spanish flu, we had the St. Patrick's Day parade. We had a congregation of people getting together, and subsequent to that, there was a spike in cases. In St. Louis, they canceled their St. Patrick's Day parade, and the number of individuals who came down with Spanish flu was much less. Now, as we talk about flu in general, every year we have a vaccine that's put out, and typically our vaccine is based on what happens in the southern hemisphere, down in Australia and New Zealand. You had shown at the beginning of the program, the vaccines are not necessarily very effective, but they do work. But the other good thing that we have for influenza is we have treatments. We have antiviral drugs that work effectively if you take it within 24 to 48 hours. So what we need to do is obviously hit the preventative end with the vaccines, and then should someone become ill, we have the treatment part. With COVID-19, we don't have either. And I think that fuels the fear and the panic and the anxiety in the community. We know how to prevent spread of viral illnesses, but we have no control in this. And currently we have no control. What we're seeing is a worldwide spread. We have many level 3 countries now where there's widespread illness. And we're looking at data coming from China, coming from South Korea, and coming from Italy and the rest of Europe now. And we've been spared some of the horrific numbers here in the United States. I think to date we've only had 36 deaths. I believe we have about 1,215 cases that are being evaluated by the CDC. Now, as I'm throwing these numbers out, these numbers change hour to hour, day to day.
And you and I both agree that any death is tragic.
Horrific, horrible.
This is destroying a family, destroying a human being. I find it fascinating that you don't see often things like the SARS, 2009, that epidemic. That had a huge mortality rate, a huge CFR, yes, according to the World Health Organization. But nobody died in the United States, and we had like 900 cases here. You would have expected at least 8 to 9 deaths. And I think one of the challenges is that when you start comparing geographic locations as far as CFR, it's influenced by the care that is provided once people get ill. The CFR is. I think it's a huge challenge for creating a public policy. I like to emphasize just what you said, that if you have that fever and cough, you ought not to be visiting people that are older.
Absolutely.
I'm not so sure that canceling everything, knowing the fact that most of us are not in that immune compromised group, that if a bunch of people that are not immune compromised want to go to a football game, to me it's just like going to a game where there's a lot of people with influenza, because we do it all the time. You and I both worked in emergency rooms.
Yes.
How many times did you get influenza during the winter months? That was just not of whether you got it or not. It was just a question when you got it.
Absolutely.
And that, think of the implications if we started to shut down all aspects of society. And it's amazing because everything is so interrelated. If your grocery store runs out because the truck drivers or somebody working in a warehouse decided we're not coming in because COVID-19's out there, I think there's almost a duty we got to dial back, as you've emphasized earlier, on some of this incredibly intense passion. This is not the meteor hitting the Earth. This is not the asteroid landing in the Gulf of Mexico.
No, I totally agree with you. And it's interesting. I was looking at some of the data that was coming out of Italy, and the population there tends to be about 10 years older than the average population here in the United States. And it does have a much greater impact on the quote-unquote elderly, which is defined as 60 and above. It kind of hits it home, doesn't it?
Getting close to home there.
Yeah,
Plus.
I know. I'm at the doorstep. So anyway, what happens
I can't see the doorstep.
So what happens is, obviously, there are at-risk populations. You and I know that, and I think we've conveyed that to the community. Those that are over the age of 60, anyone with a compromised immune system, if it's a cancer patient on chemotherapy, if it's a patient that has HIV, it could be someone with a rheumatologic disorder. Those are the individuals that we are most concerned about. As we're speaking here today, there's some data that's supposed to come out in the next day or two on pregnant women and even breastfeeding.
Yes, thank you.
Yeah. And we don't have that information yet.
I've been looking for, thank you.
As a matter of fact, I read where I believe the CDC and the World Health Organization is going to be putting that data out later today. So obviously,
stay tuned.
Stay tuned. Absolutely. We learn a lot. We learn a lot in the process here. 6 years ago, when Ebola presented itself in West Africa and we were introduced to it, there was a little bit of anxiety and there was some fear, and very similar to what we have going on now. And we did a lot of homework, and we learned a lot. And we took some of those lessons and we applied them today. Okay.
Tell me what we've applied today from Ebola.
Okay.
That was an interesting time.
That was a very interesting time. Well, obviously we learned at the source that it was not being managed and handled properly. And to sit back at a distance and try to manage it when it comes to your doorstep, that doesn't work. Get it early, get it at the source. We didn't do that real well this time.
No, we didn't.
No, we didn't.
But the transmission for Ebola,
correct,
and for the respiratory diseases is significantly different.
That is correct. we are dealing with a much more virulent condition with COVID-19, much easier to transmit.
It's respiratory spread.
That's
Our
correct.
coughing and our sneezing and our Ebola is for the most part contact, bodily fluid contact,
Correct.
and barriers work well for people around them. It's not the kind of thing that is as readily transmitted as are the respiratory pathogens, such as SARS and influenza. Just before we close out, should healthcare providers, this is a technical question,
Okay.
I've been scratching my head about this, should they be wearing PPE, personal protective equipment, for everybody that presents with a fever and cough?
I'll share with you my personal opinion, okay? And both of us were frontline individuals dealing with populations that are ill. If an individual comes to me and has a known contagious infectious disease, I will take every precaution so that I will not become ill, and also my office staff, clinic staff. I don't want them to be ill. So yes, there are times when protective measures need to be instituted. Currently, if someone comes ill, we're putting a mask on the individual as opposed to the treating clinician, physician, whoever. Obviously wearing gloves, and the concern is transmission. As we speak today, I am not wearing a mask in the office. I am screening each patient and taking the appropriate measures based on the clinical presentation.
I cannot thank you enough, Doctor. George, it's been an honor to have you here, and this is the kind of thing that I wanted to do this program for, is to get the kind of word out there about these very important things you're sharing with us. Thanks again. This is Dr. Frank Speidel, and I want to thank everybody who's tuned in and followed us on The Doctor Is In.